Good evening and welcome. My name is Roxanne Chabot from RBC Consultants. Welcome to another SkinChat educational series webinar. This evening, we're going to be talking about the development of newborn and infant skin, a European-based consensus on the role of skincare and ceramides. As guest speaker this evening, we have Professor Lauren Schachner. Professor Schachner is a professor and chair emeritus dermatology, director of the Division of Pediatric Dermatology, Professor, Department of Pediatrics at the Leonard M. Miller School of Medicine at the University of Miami. We also have Professor Giuseppe Micali. Professor Micali is full professor, head and director residency program at the Department of Dermatology at the University of Catania in Italy, and chair of the scientific committee and president of the meeting Giornate di Terapia in Dermovenerologia.
We would like to thank our sponsor, CeraVe, for making this educational event possible.
Before we start, a couple of logistic tips. If you're having issues hearing the webinar, you can listen to the presentation using your telephone. Just select phone call in the audio pane and the dial-in information will pop up. Also, if you're having technical issues or if you would like to submit a question to our faculty, please submit your question in the question chat pane on the right-hand side of your screen. At the end of the seminar, a survey will be sent to you via email. It will also pop up on your screen. If you could please fill it out and send it to us, we'd truly appreciate it. And within 1 to 2 days of the webinar, a certificate of attendance will be emailed to you, as well as the recording of the webinar. Again, if you want to submit a question to our faculty, please use the question chat pane on the right-hand side of your screen, and I've written a little note there so you can see where you need to type in your questions. So without further ado, I will pass the floor virtually to Dr. Schachner.
Thank you, Ms. Chabot. I'm so pleased to be with my colleagues this evening. The stratum corneum and the epidermis are our first line of defense against potentially harmful microbes, allergens, toxins, and irritants that could penetrate our skin. This micrometer thick structure is so essential that we must take great care of barrier function and barrier health of the stratum corneum and epidermis throughout our lives, but especially in the first days, weeks, months, and first few years of life, when we have found that the newborn skin will take 24 months or more to structurally and functionally mature. That's why I've been really so happy to participate both in a North American and European consensus conference on skincare and ceramides in newborns and infants, and potential mitigation of atopic dermatitis as well. I'm really pleased that our work in Europe has been already accepted and shown at the European Academy in a poster and submitted to European journals for publication. The European consensus had the following objectives: review challenges in newborn and infant skin barrier integrity and in sensitive skin, review the importance of skincare use in newborn and infant skin and the potential mitigation of atopic dermatitis, to evaluate the role of ceramide-containing cleansers and moisturizer use in newborn and infant skin, and to review CeraVe clinical data and technology. We used a consensus process in our consensus conferences, and that's a modified Delphi technique. The literature on the subject is reviewed and presented, and then after group discussions, we take a vote, and it takes at least 75% of participants to allow a statement to be produced as part of our consensus. In this effort in Europe, over 100 papers were reviewed, 57 publications were used, and allowed us to form a consensus. The consensus in North America has also been published, this in the Journal of Drugs and Dermatology, with several of my distinguished colleagues in North America. A consensus about the importance of ceramide-containing skincare for Normal and Sensitive Skin Conditions in Neonates and Infants concluded that taking into consideration the maturation process of neonatal and infant skin, the application of moisturizers and cleansers containing barrier lipids such as ceramides may help maintain the protective skin barrier and soothe with long-term moisturizing benefits. Similarly, in Europe, we came to 5 statements of consensus. Number 1, the neonatal stratum corneum is not fully developed in function and structure. The characteristic stratum corneum structure in newborns and infants may contribute to increased water permeability compared to adults before it's matured. The ceramides in the lipid bilayer of the stratum corneum play an essential role in regulating transepidermal water loss and to maintain healthy skin barrier function. Skin barrier dysfunction and ceramide depletion result in a reduced skin capacity to retain moisture, and we see this in conditions like atopic dermatitis or ichthyosis in babies. In neonates and infants with atopic dermatitis, appropriate moisturization in early infants is important for the daily management of the condition. Skincare of newborns and infants should optimize stratum corneum lipid and water content and exclude agents that can negatively impact the skin barrier. Ceramide-containing skincare supports stratum corneum homeostasis, as we'll demonstrate. Parents and caregivers need to understand how to avoid irritating infant skin, whether it's normal skin or atopic skin. Cleansers close to physiological pH, 4 to 6, are preferable to water alone, or soaps, which by definition are alkaline with pHs above 7. I'm going to review these first 3 statements with you, and my distinguished colleague, Professor Macaulay from Catania, will review statements 4 and 5. So statement 1, the neonatal stratum corneum is not fully developed in function and structure. Characteristic stratum corneum structure in newborns and infants can contribute to increased water permeability compared to adults, and this can lead to a number of issues. The newborn maturation process of skin starts in the first trimester of embryonic life when a basal layer is formed, a prederm, a forerunner for the dermis, and melanocytes and Langerhans cells first appear. By the second trimester, we see the full gamut of layers of the epidermis. There's basal, spinous, granular, and stratum corneum layers. By the third trimester, the stratum corneum starts to reach fetal maturity, and it is covered, as is the whole baby, with vernix caseoso. So by 34 weeks of age, the fetus will have a well-developed epidermis, which has mature fetal stratum corneum by 37 weeks, and a process of maturation has been launched, which will take at least 2 years of life to complete. We mentioned the vernix caseoso, this lipid ceramide cell-rich covering of the baby is a naturally occurring biofilm that progressively covers the fetus during the last trimester in conjunction with the time when the stratum corneum and epidermis is doing its final fetal maturation. It waterproofs the fetus during the critical period of epidermal barrier development before birth, and that's why our skin looks like a nice plum instead of a prune after sitting in amniotic fluid all that time once we are born. So here's a baby with a good covering of vernix caseoso. It's ceramide rich. It waterproofs the baby in utero and protects the immature barrier function of neonatal skin. But not only in utero, it's been found that if we leave the vernix caseoso for a few hours, some even leave for days after birth, it also can protect the immature barrier of the newborn. It increases hydration, suppleness, and plasticity of the stratum corneum when it is left as a protective barrier for some hours or even days. This protective layer decreases the skin surface pH. That's great because it inhibits pathological bacterial growth and facilitates the growth of the appropriate commensal organisms. If we look at kind of the scorecard between structural and functional differences between infant and adult skin, we see that the epidermal thickness in the infant is thinner. It's like 7 micrometers as opposed to 11 in the adult. There's less cellular attachment, making the skin more permeable. There is less undulation in the DE junction, making it easier for foreign proteins to pass through. Less lipids, melanin, sweat. There's less natural moisturizing factor, so the water content itself won't be regulated, will bounce from higher to lower in the passage of the early days of life, and the pH is higher, more alkaline. So major differences. More functional differences. The skin immune system, babies have decreased cathelicidins and defensins versus adults, and have a different mix of the commensal organisms that will populate the adult skin. Newborns and infants are susceptible to skin barrier disruption for a number of reasons. One reason is the pH starts out higher, and that'll allow microbes that we don't want to occupy the skin surface and maybe penetrate. Less natural moisturizing factor means the state of hydration and the transepidermal water loss will be wrong, won't function as we wish. Lipids, the presence of a deficiency of essential lipids like ceramides, free fatty acids, and cholesterol will also alter the barrier function, and the thinness of the stratum corneum all make us vulnerable to increased transepidermal water loss and altering states of hydration. There has been some really nice research done around the world, but in the European consensus meeting, we looked at really nice work by Fleur and others who looked at the stratum corneum's development during the first years of life. They noted increased acidification takes place, and they noted that hydration, maturation will take place starting with the first weeks of birth, but not reached till several years of life. The stratum corneum is thinner, 7 micrometers, as opposed to the adult average of over 10, and that the lipid content, though briefly up after birth because of release of sebum, rapidly decreases. Much less lipid than in the adult, and the variations in lipid when they are severely decreased may be associated with certain disease states. For example, decreased ceramides in atopic dermatitis, in xerosis, and in ichthyosis. Fleur did electron microscopy looking at the stratum corneum, and we can see maturation towards adult thickness really is out after 24 months or so. So it takes a good 2 years or more to mature the stratum corneum, both in structure and indeed in function. Ceramides are the lipid bilayer of the stratum corneum that play an essential role in regulating transepidermal water loss and maintaining skin barrier function. They provide both a quantified envelope over the entire stratum corneum and a lipid bilayer in between the stratum corneum cells. Skin barrier dysfunction and ceramide depletion result in reduced skin capacity to remain moist. So this decreased moisture, as seen in ichthyosis, xerosis, and atopic dermatitis, is directly associated with ceramide depletion. Here we have a cartoon showing us that lipid envelope I mentioned and the bilayer of lipids in between the stratum corneum. If you will, the corneocytes are the bricks, and this bilayer is the mortar that supports this barrier wall. Corneocytes is the building blocks, and the water-resistant layer of lipid lamella encasing the corneocytes and the bilipid lamella prevent water loss and control barrier permeability. The quantified lipid envelope and the mortar-like multi-layered lipid lamella are crucial elements of the epidermal barrier, its structure and function, and they are made up of ceramides, free fatty acids, and cholesterol, which improve integrity help with moisturization, lower stratum corneum pH, are antimicrobial, and enhance the development of the barrier function in the newborn and the infant. The composition of lipids in the vernix and stratum corneum are not static after birth. Ceramides become an increased percentage of the lipids, while there is retention of a good presence of cholesterol and free fatty acids as well. There is an increase in the ceramides. If we have a decrease in endogenous ceramides, we may see skin barrier disorders that result in common dermatoses in babies, such as ichthyosis, atopic dermatitis, and xerosis, because without our ceramides, the stratum corneum becomes less competent. Impaired synthesis of the endogenous lipids adversely affect the lamellar layer, impair barrier homeostasis, and we end up with the drying, irritation, erythema, and itching of atopy, ichthyosis, and xerosis. Some really wonderful science out of the United Kingdom by Kelleher and al. Looked at early skin barrier dysfunction in atopic dermatitis. They looked at transepidermal water loss at birth, at 2 months, at 6 months, and a year. What did they learn? By measuring the transepidermal water loss at birth, they could find what babies had increased or normal transepidermal water loss. The babies were then evaluated at 6 and 12 months by Sporat and other scales. There were almost 2,000 babies evaluated, and what did they see? They saw that at 6 months, about 19% of the babies presented with atopic dermatitis, and those who presented with atopic dermatitis had a significantly increased transepidermal water loss at birth and at 2 months. So we can actually pretty well predict by looking at transepidermal water loss, even at 2 days of age, what babies are going to go on to have clinical atopic dermatitis. Because those who had normal transepidermal water loss at 2 days or at birth had a much less likelihood of developing atopy. Interestingly, the same study suggested that transepidermal water loss increase at birth could also be a risk factor and or prognosticator of food allergies later in life. We will have a polling question, and it is, what is the atopic march? Is it a flare of atopy in early spring weather? A well-known fundraising walk from Palermo to Catania to benefit research? A symphony by Tchaikovsky after the March Slav? The progression of early and severe atopic dermatitis issues, or none of the above? What do you think? Well, the majority of you nailed it. It's the progression of early and severe atopic dermatitis issues. And this is the atopic march, and Irvine and others published a year or two ago some really interesting data that showed a significant proportion of children that present with early and or severe AD and a family history of AD will go on to develop not only chronic atopic dermatitis, but go down the atopic march to asthma, rhinitis, and other comorbidities. If we could mitigate or attenuate these early onset atopic dermatitis patients with the appropriate use of therapy, including appropriate lipid-based emollients with the essential ceramides and other helpful emollients, is it possible to attenuate the march and help the kids go on to better health? And that's a very, very important issue in atopic dermatitis. And it's been looked at in a number of ways. I am having trouble advancing at this time. Okay. Make sure we didn't skip anything. Good. In neonates and infants, with atopic dermatitis, appropriate moisturization in early infancy is important for the daily management of the condition. That's not only my opinion, but this is an opinion by the American Academy of Dermatology's position paper on the treatment of atopic dermatitis. And we'll look at that. Essentially, what we're talking about in atopy is a disruptive skin barrier that allows allergens, be they microbes or contactants, or easy entree through a lipid-deficient stratum corneum epidermis to activate the immune cells, leading to inflammation. The use of physiological or low pH cleanses and appropriate moisturization restore barrier function, let the lipids do their mortar job, and halt the invasion of potentially harmful proteins. So the use of emollients help control transepidermal water loss, help improve elasticity of the stratum corneum epidermis in the skin, restore the barrier function, not allowing antigens in, and may prevent progression to atopic dermatitis flares and ultimately the atopic notch. There have been guidelines that support the one I quoted. Among others is the Guidelines of Care for the Management of Atopic Dermatitis, published in the JAD, in which evidence-based guidelines for AD support the use of moisturizers for skin hydration and atopic dermatitis symptom improvement. In fact, the guideline recommends moisturizers be used as a primary treatment in mild disease and in conjunction with other agents for more moderate and severe disease. Let's look at this from yet another point of view. Our friend here wants us to realize that moisturization in atopic dermatitis decreases steroid use, which makes patient and doctors happy, reduces itching, has been shown to reduce major evaluation techniques of atopic dermatitis, the SCORAD, the EASY, and the IGA, improves quality of life indexes, reduces the number of flares. Now that is again important because that is a marker for the atopic notch. Increases the time between flares, again important. May help decrease progression of atopic dermatitis in atopic-prone newborns and play a role in reducing contact dermatitis as well. There have been some interesting studies starting about 6 or 7 years ago, this one out of Scandinavia, where moisturizer use improved skin condition in babies who were xerotic at 6 weeks. What were they doing? They looked at babies who at 6 weeks had xerosis. A group was giving oil-based skincare, another group wasn't. 75% of the children who had the oil-based skincare had normal skin at 6 months. Only 37% of these kids who were xerotic and probably atopic prone then had normal skin when they didn't get emollients. This was followed by more structured studies by Simpson and others. This was a study in the US and the UK. They looked at atopic prone children who had atopic siblings and parents, started emollient care. They found at 6 months that the degree of atopic dermatitis that would have been predicted normally seemed to be reduced by 50%. A similar study by Haramaki in Japan found about a third decrease in the predicted breakout of atopic dermatitis in kids who were prophylactically given emollients. Unfortunately, with the passage of time, there have been several subsequent studies that have not confirmed this prophylactic role, keeping atopic dermatitis from emerging in newborns with the use of emollients. But numerous studies, including those that I've shown you, have confirmed a decrease in atopic flares and severity, and that has been widely established. So it's been my pleasure to review with you the first 3 statements of the European Union consensus publication done with colleagues from 8 different countries in Europe. That the neonatal stratum corneum is not fully developed in function and structure. The characteristic stratum corneum structure in newborns and infants can contribute to increased water permeability compared to adults. Ceramides in the lipid bilayer of the stratum corneum play an essential role in maintaining transepidermal water loss, keeping it down, and maintaining skin barrier function. Skin barrier function, as an atopic dermatitis and ceramide depletion, result in reduced skin capacity to retain moisture. And that is seen in some other disorders that we discussed with you as well. Decrease the ceramide, you decrease the barrier function, you increase the transepidermal water loss. In neonates and infants with atopic dermatitis, appropriate moisturization in early infancy is important for the daily management of the skin's condition and atopic dermatitis. At this point, I'm going to turn it over to my distinguished colleague, Professor Giuseppe Macaulay of Catania. Giuseppe, take it away.
Thank you, Dr. Schachner, for your kind words. Thank you for the organizer for giving me the opportunity to be here. Let's move to the statement. And, okay, no.
So just click in the middle of the screen, Dr. McCallie, and you should be able to move them forward.
Okay. No.
Would you like me to move them for you?
Yeah, please. Yes, thanks.
Okay. So we're starting with a polling question.
Sure.
So the audience is voting.
Roxanne, I don't see anything in my screen.
The polling question is open.
But I don't see the question in my screen.
Okay, can you see the results?
No.
No.
Okay.
Let's see. Can you see this slide? Statement 4 and 5.
Not really.
Okay. Let me see. We'll
Okay.
try to
No.
I'm going to stop sharing the screen and I'm going to share the screen
here we are.
again.
Okay.
You got it?
Yes. Okay. Sorry
Yay.
for this inconvenience. Okay, let's move to statement 4 and 5. As you can see here, statement 4 and 5 states that parents and caregivers need to understand how to avoid irritating infant skin, whether normal or atopic. Cleanser close to physiological skin pH, 4 to 6, are preferable to water alone or soap, which normally have a pH between 8 and 10. Skincare on newborn and infant should optimize stratum corneal lipids and water content and exclude agents that can negatively impact the skin barrier. Ceramide containing skincare supports stratum corneal homeostasis.
Yep, you moved the slide there.
Okay. Let's see what scientific support this statement. Importance of skincare. Gentle cleanser and application of physiological lipids can improve skin barrier homeostasis. Early skincare may also be beneficial to common dermatologic conditions such as atopic dermatitis. Also, the daily use of moisturizer that contain humectants and ceramide decrease atopic dermatitis flares and reduce the need for topical steroid treatment. Why it is so important to keep the skin barrier function? Can you please move for me, Roxanne?
Sure.
Okay. Compromised skin barrier is prone to toxicity. Achievement, as Dr. Schachner previously says, achievement of full epidermal maturity may take up to 2 years. 25% of infants and young children may have an impaired stratum corneum absorption. Also,
So you're moving the slides there, Dr. McKenna.
Allie. So don't touch your mouse.
Okay. No. Can you go back? Excuse me, Roxanne.
Absolutely, not a problem.
Sorry for that.
And we're at transcutaneous poisoning.
Okay. So a newborn and infant, as I was saying, are particularly at risk to poisoning from transcutaneous exposure because of their high surface to weight ratio. Depending upon how much has been absorbed systemically, some topical agents like isopropanolol, benzocaine, pyretrins, hexachlorophene, lindane, and salicylic acid that are harmless in adults may cause methemoglobinemia, respiratory distress, neurologic toxicity, and even death in neonates and infants. The use of lactic acid or salicylic acid can lead to systemic toxicity in neonates and young infants, and especially in those with skin disease with impaired skin barrier. So it's very important when we use some topicals to make sure that there are no risk of systemic absorption. Let's move to another important concept. Ceramide play an important role in skin barrier integrity. Without the proper ratio of ceramide, the skin's barrier may become compromising, leading to dryness, irritation, erythema, and itching. Exposure to hot water, cleanser with elevated pH, certain chemicals and other environmental factors may also contribute to skin barrier damage. Why it is important, the pH of a component? What happens when the stratum corneum is more than 6? Remember that the physiological skin surface pH is between 4 and 6. When do we use a product which has an elevated pH? What we need is that we could face increased inflammation, decrease stratum corneum cohesion, and decrease permeability barrier. So the message is that keeping pH within normal values results in a more physiologic microbiome, repair of barrier, increase epidermal water differentiation, and reduce inflammation. Here is a list of common cleansers, and then you will see on your right side the corresponding pH. So as you can see, most of the available cleansers, they have a pH which is over 6, and this is not good. So the only product who may have a physiological, close to physiological pH are the Syndet bar and the multivesicular emulsion system based cleanser. Let's take a look to the role of moisturizers. Neonatal infants greatly benefit from their frequent use. Do not forget that all the guidelines for atopic dermatitis, they recommend the use of moisturizers since the early month of age, early days of age. Moisturizers, they help skin retain moisture. They help protect the skin against environmental aggressors and maintain skin barrier integrity. Formulation that contains ceramide mimic physiological lipids, supporting homeostasis and improving skin condition. But what are the features that an ideal moisturizer should have? Should be safe, should be effective, should be near physiological pH, should not contain any additive, should not contain any fragrance, not sensitizing agent, and in addition should be pleasant to use, and most importantly, should improve lipid and water content on the stratum corneum. Ceramide containing moisturizer. This is something very new. Remember that there are 9 different ceramide, which are labeled 1 through 9, and CeraVe, this new product that contain ceramide, contain 3 different ceramide, 1, 3, and 6/2. What are the main features of this CeraVe product? This CeraVe, I would say, technology and components. Please keep in mind that all products, CeraVe include a list of different products, all contain ingredients integral to formulation that benefit skin barrier, all contain ceramide, all are fragrance-free, all are non-irritating and gentle on skin, and of course, all are hypoallergenic and non-comedogenic. Most also contain hyaluronic acid and MVE technology. They all limit the percentage of parabens, sulfate, endocrine disruptors, dyes, propylene glycol, mineral, nut, and coconut oils. But what is the innovation of this technology? Why it's so innovative? Can you move with Roxanne, please? This CeraVe multivesicular emulsion system is a patent MVA sustained release technology. What is exactly? It's a multi-phase oil and water emulsion system that consisting of a series of concentric spheres of oil and water phases. MVE traps ingredients into its oil or water layers and release them slowly, layer by layer, into the skin over time. As you can see in this image, in which is shown progression release of moisturizing ingredients versus quick bursts of traditional emulsion. Let's take a look to the scientific evidence of this new technology containing ceramide. There are a few papers that I will go through with you just to show the result of these studies. This is a studies that was done in 2020 and was testing how much and how long do the test product guarantee hydration of the skin compared to currently used emollient creams. So you see there were different products. There was the CeraVe cream versus CeraVe lotion versus reference cream A, B, and C, and no treatment. So each patient has 6 sites treated with 6 different products. Those are the results. CeraVe moisturizer significantly increased skin hydration for more than 24 hours after a single application, which is, in my opinion, very important. By comparison, the simple emollients tested imparted insignificant level of hydration. There was no difference between the effect of CeraVe cream and lotion preparation. What is the message? That in contrast to traditional emollients, which require 3 to 4 applications per day, the test product imparted sustained moisturization for more than 24 hours. And this, from a clinical point of view, is very important, as the use of a single single application a day, reduce the number of applications and help lessen the burden of dry skin management. This is another study. It's called the Restore. It's a little bit more complicated. Again, the objective was to investigate whether a cream containing skin lipids, ceramide, in this case, triglycerides and cholesterol, can reinforce the skin barrier. So this is a double-blind intra-subject control study on 34 participants. with a dry eczema prone skin, 4 weeks twice daily treatment on the right or left forearm and lower legs. And those are the results. The results showed that the test cream increased lipid levels deep within the stratum corneum and enhanced the lipid structure. Enhanced lipid structure was significantly associated with improved skin barrier integrity. Improved skin barrier structure was accompanied by increased hydration, decreased dryness, and reduced sensitivity to irritants. What I think was very important in this study is that as you can see here, all of these results were supported by new technology, which consisted of lipid calculation in the stratum corneum measured by spectroscopy, by reduced transepidermal water loss after tape strip, multiple tape strip, and less irritation data. So CeraVe delivers barrier reinforcement compared to paraffin-based emollient, increasing skin hydration water content, decreasing skin dryness, and increasing protection from irritants. And CeraVe, last but not least, was more cosmetically acceptable than the paraffin-based emollient. Lastly, we have another study. In this case, the CeraVe was used on adults and children with atopic dermatitis. The study was aiming to evaluate safety and efficacy of 6-week CeraVe hydrating cleanser followed by CeraVe moisturizer cream on 151 subjects. Of these, 33 were children and 118 were adults with mild to moderate atopic dermatitis. Interestingly, there is also a sub-analysis of the 33 patients who were below 12 years. And as you can see on this slide, reported atopic dermatitis symptoms at baseline and after 42 days of cleanser moisturizer use. As you can see here, most of these patients with very dry skin move to dry skin, and also crust or very crusty were reduced drastically, reduced at day 42, as well itch, and most of these patients with very itch move to itchy skin. So the AD symptoms 100 moved to 22. So definitely the association of the cleanser and the moisturizing cream was very effective. Also, there is the quality of life parameters as reported by the guardians. Of course, those were children less than 12 years, and probably they were not able to state their quality of life, but the guardians fill up the quality of life form, and those are the results. As you can see here, negative impact of appearance drastically reduced, pain and irritation and improvement in skin condition, as you can see, were improved. Conclusion: the skin of neonatal infants exhibit distinct anatomical and functional property. They may result in barrier disruption. Infant skin functionally is still developing, as indicated by elevated transepidermal water loss, skin surface pH values, and elevated desquamation. Neonate and infant skin is more fragile and susceptible to infection, chemicals, and thermal damage. Skincare for neonatal infants should be safe, effective, and fragrance and sensitive agent free. Should be pleasant to use, containing ingredients that benefit the lipid and water content of the stratum corneum, such as those products containing ceramide. Several studies have shown that skincare, including specific cleanser and moisturizers, can reduce the risk of atopic dermatitis in atopic dermatitis pro newborns. And the study that I have discussed with you previously proved that there is evidence that support that this product may be beneficial. More robust studies, however, are needed to confirm the perceived benefit of skincare in neonates and infants. I thank you for your attention.
Wonderful. We do have time for some questions. Again, please use the question chat pane on the right-hand side of your screen in order to submit your questions, or if there's any additional questions afterwards, you can always send them to info@rbcconsultants.com. Thank you again to CeraVe, our sponsor, for making this educational event possible. So we will pass it along to the question period. One question. Oh, Dr. McCallie, you've disappeared on us. So the first question is, why is using traditional soap a problem with infant skin?
Roxanne, do you mind? Can you say it again, the question? I have some problem with the connection.
So why is using traditional soap a problem with infant skin?
Dr. Schechner, you want to reply or you want me to reply?
Oh, in my opinion, traditional soap by definition is alkaline, a pH of 8 and up, and that is going to affect the barrier function adversely. And that's why we say no soap during the first months and years of life. Professor McCauley?
I fully agree with you, and normally dermatology do not prescribe regular soap, right? Normally they prescribe, as I show in that slide, Syndet or new generation of soap, because regular soap, which many thinks is a natural, but is not, I mean, it could be natural, but still has a pH which is not acceptable for baby skin. So in Italy, many people prefer and think that handmade soap because it's natural and is very beneficial, but it's not. I have a hard time trying to convince the mother of using more advanced soap, which guarantee a pH close to normal skin.
And Professor McCauley points out even the so-called naturals are not naturally good for baby skin, because the increased pH will be an irritant unto itself, but also will halt the colonization of acceptable and useful commensal organisms and increase the potential for penetration of pathogens.
We have another question. What contributes most to an incompetent epidermal barrier in infants?
Wow, that is a big question. That's a beauty. I'm willing to start, and my start is the babies need more time to mature, and we gave kind of a big scorecard of stratum corneum thickness being less, lipids being less, defenses and cathelicidins. There is a whole group of both structural and functional maturation processes that the baby has to go through. And before the baby gets there, by 2 to 3 years of age, the baby's more vulnerable.
Dr. McCallie, did you want to add anything?
No, I think that Dr. Scheck, I mean, it's a very complicated issue, definitely. I mean, it's the ability is to make it simple, but there's a lot of basic research also pointing out what Dr. Scheckner said. And I think it's very important to be aware of this, be aware of things that they may damage the stratum corneum, and using the correct approach, the correct treatment, and the correct skincare.
The next question is, what are the key benefits of MVE technology in skin products for young children?
As I show in that cartoon, MVE technology is able to gradually release the product, not immediately as the regular product do, like a quick burst, but gradually the release and giving the chance to penetrate better the skin. So this MVE technology, in my opinion, is very interesting. It would be more interesting, in my opinion, if it would be a study that monitor the gradual release of the product through the skin. Something that probably is a bit complicated, but can be done to measure exactly and to prove with some technology how this product penetrate the skin. But it's a slowly release with that little spares, slowly release of the product through the skin.
And what is the role of skin probiotics in development of AD in high-risk patients? Any thoughts?
Lots of controversy. Of interest to me, a lot of the studies I've seen with probiotics did not really show the type of benefit that people had hoped for, despite the fact there was some very vocal enthusiasm in the beginning. There is work with prebiotics, things that help colonize the gut with favorable organisms that actually deserve a little bit more looking at from my point of view, from what I've seen for now. I'd be interested to get the view from Professor McCauley.
The idea is very, very interesting. The idea of being able to control the presence of some bacteria on the skin. We know that Staph aureus play an important role in triggering atopic dermatitis, and to control the microbiome, I think is very exciting. It's an exciting area. To me, a lot of things need to be done more studies, especially clinically, because the idea is very good, but the clinical results are not so exciting. We have tried this product, but we haven't seen very good results at clinical level. So the idea is very important, and I'm sure that studies in the future will lead to some improvement of some better knowledge of how to control the microbial presence on the skin of atopic patient, atopic dermatitis patient. But so far, we are a little bit far. What do you think, Larry? To reach good results, clinically good results?
I think, as you sometimes have to say to little children in the back seat of the car, we're not there yet. But I do think both Dr. McCauley and I want to give words of encouragement to those who are researching ways to alter the impact, for example, of Staph aureus on the skin, be it by internal use of probiotics or external, appropriate, scientifically driven manipulation, potentially, of the stratum corneum and other organisms on the skin as a potential safe approach to giving us another weapon in atopic dermatitis. Atopic dermatitis is so interesting now with the new therapies coming, the JAK inhibitors and the biologics, but something simple that safe, that can help with the flora on the skin, I think would be very exciting.
What should I know about the use of emollients and the atopic march?
Based on what I saw from Alan Irvine's very interesting work and the work of many others, there is a lot of upside to using emollients. There seems to be agreement that the use of emollients can decrease the number of flares, the time to flare, the severity of flares. We're not talking about a cure, and we're not talking about a successful prophylaxis, unfortunately, but we are talking about something that mitigates and attenuates the severity. And if Irving and his group have it right, and they're very good, then if we can decrease the number, frequency, and severity of atopic flares, we should be able to have some positive impact on the likelihood of proceeding down to the atopic march, to respiratory, to nasal, and maybe to GI comorbidities, atopic dermatitis.
Yeah, it is a very interesting question. Of course, there are no definitive data. What I can say is that keeping the skin, baby skin in good health is very important, as all the guidelines recommend. Having real world data means following patients for years and years, and patients who have been treated with moisturizing, people who were not treated with moisturizing, and compared it to groups that should, of course, be the samples should be similar age, similar history of atopic dermatitis, family history. In my opinion, it's very complicated to have definitive data. But my feeling is that it's very important to keep the skin moisturizer from the beginning. It's very important. Then, if it really will affect the atopic march, it's something that need to be proven. But in the meantime, we need to keep the patient's skin in good health using the appropriate moisturizer, of course.
So one last question, actually it's a two-part question. Can long-term use of ceramide containing products be harmful? And in the same trend of thought, is the use of CeraVe products suitable for long-term use?
Again, Larry, you want to comment on my answer? Again, all the guidelines recommend to use moisturizer from the beginning. Whenever I have a patient who has a family history positive for atopic dermatitis and does not have clinical atopic dermatitis, but only dry skin, I start to use moisturizers, definitely. There are no limit for moisturizer as long as they are approved by dermatologists. So even the ceramide are normal component of the skin. So why they should harm the baby skin? We are adding component cream, which is designed for skin babies, containing products that are normal components of the skin. So there is no need to be worried on long-term use. Larry, what is your?
So Dr. McCauley answered with scientific expertise, and I'll just add a little, because he said it all beautifully. I'll add a little lighter note, because parents do ask me and ask all of us, any danger for me using too much emollients, any risk with too much emollients? And I tell them, if they hug their baby and the baby flies up to the ceiling, they used a little too much emollient. Otherwise, we're going to be okay.
I agree.
Well, on that note, we'd like to thank Professor Schachner and Professor McCauley for this very enriching and innovative talk on a continuously evolving therapeutic area. And thank you all for joining us this evening. We truly appreciate it. Good night, everybody.
Thank you.
Thank you. Be well.